Welcome back, everyone, for the third and final session today as part of our second day of the 2021 Virtual PKD Summit. It is my great pleasure to introduce Roxanne Papineau, who will be discussing the importance of diet with PKD. Roxanne is a nutritionist with a bachelor's degree in nutrition from Laval University in 2005. She received a specialized graduate diploma in functional nutrition and health from Laval University. She is a clinical nutritionist in nephrology at the IUCPQ for the last 15 years. She is a lecturer for the bachelor's degree in clinical nutrition and the doctorate in pharmacy at Laval University. Roxanne is the president of the RNNQ, which is a group of nutritionists in nephrology in the province of Quebec. She is a member of the scientific committee de Venier, which is a multidisciplinary group in nephrology. Roxanne is also a member of the Renal Health Expert Committee associated with the Ministry of Health. She has created several teaching tools for patients, as well as the author of 2 cookbooks for nephrology and cardiology patients. She has written articles on gastroenterology and nephrology for the FMOQ and the OPDQ. She has participated in more than 75 conferences given in connection with nephrology and gastroenterology for doctors and other health professionals. Roxanne is an Epicurean mother of twins, a triathlete, and passionate about cooking. Roxanne, so good to have you here, and we look forward to your presentation today.
Hi everyone, my name is Roxanne Papineau, and I'm a renal dietitian. I work at the Institut Universitaire de Cardiologie et de Pneumologie de Québec. I've been working with CKD and PKD patients for more than 15 years now, and I'm also the president of the Regroupement of Renal Dietitians in Quebec. I am very glad to have been invited today to talk to you about kidney-friendly diet for PKD. Please apologize for my English that is far from perfect. I will try to talk slowly to be sure that you understand me. The learning objective for today is to review the importance of nutritional intervention at early stage in the treatment for PKD patients, but also to discuss about the new emerging data that in PKD nutrition studies. And I want to present you what looks like a renal-friendly diet in the real world for PKD patients. In my practice, I can say that PKD patients are the ones who show the most interest in nutrition, and they are the most motivated to change their habits. But often the information available in nutrition is conflicting. Many patients look on the internet to have information. They want to see dietitian, but only 60% have seen a dietitian for PKD. And the access is limited, and the referral for a dietitian is it's not at early stage. It's when the patient have kidney failure. So it's not easy for patients to have the right information about nutrition. What is the role of diet in the prevention of ADPKD progression? When I began my practice 15 years ago, there was no specific recommendation for PKD patients. These patients were seen in the clinic with other CKD patients with low low kidney function. There was no specific recommendation to slow the disease. And often the doctor referred the patient to me at late stage of disease in pre-dialysis clinic. So now we have more information about what we can do to help slow the progression of the disease. Most of the studies are made with animal, with the rodent model of PKD. There are few clinical trials, but they are done with small group of patients with short duration, but there are many encouraging data in the recent years, in the last 10 years, I can say. There are many components that are potentially involved in PKD diet in the progression of the disease. We'll talk about some of them today, water, sodium, protein, phosphate, and also talk a little bit about carbs and food caloric restriction. But first of all, I have to explain one big word, the vasopressin. What is vasopressin? Vasopressin is the antidiuretic hormone. It's an hormone that is released when the osmolality of plasma increases, so when the concentration of the blood is high. It's an hormone that prevents dehydration by reabsorbing the water. But we know now that PKD patients have a defect in the urinary concentrating ability. So they are prone to have elevated vasopressin level. And the greatest advance in PKD research in the last years has come from the recognition that the vasopressin is implicated in the cyst formation and growth. So there have been a lot of research to find a way to reduce the vasopressin to help slow the progression of the PKD. One way to reduce the vasopressin is hydration. You already have the information that PKD patients have to drink a lot, but why? The reason is that drinking a lot of water can lower serum vasopressin. But if we want to keep the vasopressin low all the day, patients have to drink all the day and also during the night if they go to pee. We have to keep the urine very diluted. So it's important to drink during the day, but it's also very important to drink with meals because when we are eating protein and sodium, and these nutrients is implicated with a release of vasopressin. So it's important to have a glass of water with each meal and each snack. So in generally, the urine should be very pale in color. In PKD clinic, what we do is that we measure urine osmolality. So we have a target below 280 milliosmol per kilogram of water. And it is the target when the vasopressin remains low. There are two studies, an interesting study about the effect of water in PKD. The first one is the drink study. This study was, the goal of this study was to compare two groups. One group that was supposed to have high water intake, and the other group ad libitum water intake. They have to self-monitor their fluid intake, and they also have a special stick to measure specific gravity of the urine. So it's the concentration of the urine, and they have to drink more if the urine was too concentrated. So they use a smartphone application, and both groups have as controlled diet with low sodium and low protein. They want to see the effect of high water intake on urine osmolarity. So after 8 weeks, the high water intake group have reached the target of osmolarity just by drinking a lot of water. So it's very interesting to see that it's possible just by drinking more water. The average urine volume for the high water group was about 3 liters per day. The other study about water and PKD is the PREVENT-ADPKD trial. This study is already finished and the result is likely to be released in the late 2021. It's an open label randomized control that tells the hypothesis that prescribed rider will reduce not only their vasopressin, but also the kidney volume with ADPKD. So it will be interesting to see if the fact of drinking more water can have an impact on kidney function and kidney volume. My patient always asks to me, what can I drink? Because I know I have to drink more than 3 liters per day, but can I eat something else than water? So yes, water is the first choice, but other sugar-free, low protein, low sodium, low phosphate drink can be consumed. There's a controversy about coffee, because for a long time we thought that coffee was bad for PKD, but recent studies failed to show these bad effects. So coffee drinkers don't have different size, kidney size compared to non-coffee drinker. So generally, I recommend the same recommendation as general population to limit caffeine like 2 cups per day, to get more place to drink water. There are some tips to increase water intake. First of all, with each meal and each snack, drink a big glass of water. And also drink a glass of water every time the urine is too much colored. Also, you have to drink 1 or 2 glasses of water when you are physically active. You can use a big graduated bottle as a reminder and to set daily goals. And it's very important to bring the bottle with you everywhere. I always ask my patient, where is your bottle? We can add some fruit, herbs, or spice in water to add flavor, or also add some citrus juice dilute with water to have a boost of citrate. I will talk later about citrate. And there are many applications that can help track water consumption and have some reminder to help you drink a lot. The second point that is very, very important for PKD patient is sodium. We know that sodium is a bad guy. We know that sodium has bad outcome for all kidney disease and general population, of course. And hypertension is the most common manifestation for PKD patient. We have very severe goals for hypertension target. And what we know is that PKD patients are very sensitive to sodium. They have an increase in blood pressure when they eat too much sodium. Results from 2 large studies, the CRISP study and ALT-PKD study, have shown that high sodium intake seems to be associated with increased cyst growth and faster decline of kidney function in PKD. But independently of cyst growth, we know that sodium is bad for hypertension, proteinuria, and other cardiovascular outcomes. Sodium has also a link with vasopressin because it's a big osmol. Sodium accounts for about 15 to 30% of urinary osmoles. So when we eat a lot of sodium, the urine is more concentrated and the vasopressin is released. So it may have an impact on cyst growth. It's important to start the sodium restriction at early stage of the disease. But you know, the recommended intake of sodium is less than 2,300 milligrams per day. It is the same for the general population. So we should all eat less than 2.3 grams of sodium per day. In PKD clinic, we use the 24-hour urinary collection to measure the sodium intake because what we see in the urine is what the patient eats. So the target is below 100 millimole per day. So I will always say to my patient, if I catch you on the autoroute at 170 kilometers, you will have to pay a big amount of money to me. Where does the sodium come from? My patients sometimes say to me, I don't use the salt shaker, I don't eat salt, but the salt shaker is just about 10% of the intake of sodium. The majority of sodium came from processed food, restaurant, and it's always a big amount for a kidney patient. We know that there are very salty food like hot dog, pizza, fast food, and soy sauce, chips, etc. But sodium can be everywhere. If you want to know if there are too much sodium in a product, we have to look at the nutrition fact table because sodium is always written in the table. What is a good choice? For a PKD patient, for a CKD patient, and also for general population, a good choice, a low sodium choice is always below 140 milligrams of sodium per portion. It corresponds to about 6% of the daily value. So when you look at your cereal, your bread, your sauce, it's very important to try to pick those that are low in sodium. In this example, we have a tomato juice. It contains more than 500 milligrams of sodium for just one glass. It's a huge amount of sodium because a normal meal should be under 600 milligrams. There's also a lot of sodium in restaurants, and we don't have the nutritional labeling available to help us making good choice. It's always saltier than at home. So it's almost impossible to keep the track of sodium when we go to restaurant 2 or 3 times during a week. There are better salt alternatives that we can use to add flavor. You may know the Mrs. Dash, McCormick, but there are also brands that offer a low sodium alternative. It's important to use herb, garlic, onion powder, some black, pink, green, citron pepper, and we can also use citrus zest, ginger, and all these natural flavoring. I also use with my patient the Renee's Asian Sesame Vinaigrette to replace soy sauce. It's really, really good. It's important to avoid some salt alternatives that contain potassium chloride because these salt alternatives can cause hyperkalemia with patients with kidney disease because of high rate of absorption of these potassium. Now I will talk about protein. We all know that high intake of protein is not recommended for CKD patients. A high intake of protein is associated with high hyperfiltration of the kidney, but also with proteinuria. For PKD patients, we saw in animal study that low protein diet seems to reduce kidney weight, renal volume, and cyst area. But it's important to know that a high protein intake is associated with high vasopressin release. Our protein intake also have an high acid load that is also bad for the kidney. We have few PKD human studies on the effect of protein on PKD. We know that protein restriction may delay the progression to end-stage renal disease in CKD patients. But it's have to have a conflicting result for advanced PKD patients. There are many conflicting factors that can be involved because we have to look about the protein type. We know that plant-based protein and animal-based protein does not have the same effect on the kidney. Generally, I try to recommend the same amount of protein for PKD patients than for the general population. So 1.8 grams per kilogram per day. When the kidney function is very low, we can try to reduce a little bit more, but in clinic, we try to recommend a normal protein intake, but no excess in protein. Protein are everywhere. We have protein in animal products, but also in grain, in plant-based protein. But the major contributor to the intake of protein are meat, poultry, and fish. For each ounces of meat, we have about 7 to 8 grams of protein. So if we don't want to eat too much protein during the day, we have to reduce the size. Generally, the tip to limit protein are to reduce the serving of meat, poultry, or fish, and to eat just one meal per day with these protein. So for the other meals, we suggest to eat substitutes like egg, cheese, tofu, legumes, nuts, but also tempeh, edamame, peanut, or nut butter. We try to avoid snacking with cheese because it adds a lot of protein, and also to avoid doubling protein source in the same meal, like cheeseburger. We also have to watch for the number of dairy portions. Generally, we recommend to limit to 2 servings per day. And we can also change milk with a plant-based version like almond milk, cashew milk, because they do not contain protein. What about the low osmolar diet? The low osmolar diet is a combination of high water with low sodium, low protein intake, but also low additive. It helps maintain the urine always diluted, and the release of the vasopressin is very low. So the urinary osmolarity target is below 280. The updated Canadian expert consensus published in the last years that recent evidence supports the benefit of low osmolar diet and dietary sodium restriction in ADPKD patients. I like to use the low osmolar diet in clinic with my patient. The urine osmolality target is very easy to achieve by combining the kidney-friendly diet with high hydration. It's safe in the long time, patients have good compliance, and it's also really kidney-friendly. It helps control hypertension, proteinuria, but also acidosis and phosphate abnormality. And what I like with the low osmolar diet is that it's consistent with the Canada's Food Guide and other health guidelines. It promotes whole food, low processed food, low sodium food, so it's really kidney and herb friendly. I use 24 hours urine collection with my patient to monitor the intake of water, but also sodium, potassium, phosphate, and protein. So it's easy for the patient to know what is the key point that they have to work on. So if the sodium is too high, they know that they have to work more about sodium. And if the protein intake is too high, we try to give some more trick to reduce protein. So what's new in PKD diet? There's a lot of research, ongoing research about nutrition and PKD. Most of them are animal study, but it's interesting to see what nutrient can have an impact on PKD outcome. The first one is phosphate. You know that phosphate is a nutrient that we have to reduce in late stage of kidney disease because of blood accumulation. But one group of researchers look at the effect of phosphate restriction on PKD mice. What they saw is that the restriction of phosphate, the lowest urine phosphate excretion was associated with lower kidney weight and cyst number. So it's very interesting. And the mice have the same amount and the same source of protein. So it's not an effect of protein source. It's really an effect of phosphate. So it's interesting to see that maybe phosphate could be linked to PKD outcome. Of course, we are not mice, we are real human, and we work with human PKD patients. In clinic, I can help my patient to limit phosphate intake just by reducing protein intake. Animal protein are the major source of phosphate, but also processed food because of phosphate additive. Additives are hidden in the ingredient list. So it's important to look at the ingredient list and to limit every food that contains the word phosphate, phosphate, or phosphoric. These additives are present in deli meat, frozen meal, processed cheese, but also in many beverages like soft drink, energy drink, or some flavored water. It can hide also in some breakfast cereal. So it's very important to always look at the ingredient list. Of course, there's a lot of additive in restaurants. So the same recommendation as for sodium is to limit the number of restaurants in a week. Kidney stone. You may know that PKD patients have an increased risk of kidney stone, oxalate, phosphate, or uric acid stone. It's caused by a low urine pH and a low urine citrate. And we think that crystal deposition causes a dilatation in the tubule that accelerates the formation of cysts. In rat model of PKD, researchers have seen that citrate supplementation seems to have a beneficial effect. We know for a long time that citrates are really good for the kidney because citrate is a strong inhibitor of stone crystallization, but also an indicator of the acid-base status. With high acid load in the diet, we saw a reduction of citrate in the urine. But how to increase citrate in the real world with real food? The best source of citrate are vegetable and fruit. Just eat a lot of fruit and vegetable. 3% of fruit with 4% of vegetable a day is enough to increase citrate. But if you want a citrate boost, you can also add citrus juice like lemon, lime, grapefruit, or orange in water to help maintain your high hydration rate. The recipe is about 4 ounces of lemon or lime juice with 2 liters of water or low sodium mineral water or club soda. Now, because it's a subject of interest, just talk a little bit about sugar, calorie, and keto diet for PKD patients. We know from observational studies in humans that PKD patients with high blood glucose or obesity have faster disease progression than healthy patients. In animal study, we saw that a mild reduction in food intake can inhibit the renal cyst growth. The calorie restriction, the intermittent fasting, the time restricting eating, all seems beneficial. We also have an animal study that showed that ketogenic diet can also inhibit renal cyst growth in animals. And maybe just the supplementation of a normal diet with ketone could replicate the beneficial effect. But we have to keep in mind that all these studies are in animals with a small duration of time. So it's not easy to replicate in the real world of PKD patients. There are ongoing clinical trials in humans, but at this time, we cannot say that these interventions are beneficial in humans. I have some concern about the keto diet for my patients because we have to remember that PKD patients have an increased risk of cardiovascular disease, stroke, hypertension, and lipid abnormality. So PKD diet have to eat a healthy diet with a lot of fruit, vegetable, whole grain, and plant-based proteins. So because the keto diet is very low in fiber, antioxidant, and micronutrient, it's a risk factor for cardiovascular disease. And it's also rich in saturated fat most of the time. As I said, PKD patients have an increased risk of kidney stone, and the keto diet, low-carb diet are both associated with urine acidification, low citrate in the urine, and high risk of kidney stone. oxalate stone, but also phosphate and acid uric stone. The keto diet is also associated with higher risk of metabolic acidosis. So I don't want my patient to have metabolic acidosis. PKD patients also have an increased risk of impaired liver function because many patients have also liver cysts. And we know that high-fat diet increase the risk of non-alcoholic fatty liver disease. So it's not recommended for a patient with impaired liver function or liver cyst to eat a very high-fat diet at this time. And we have to think about the impact on gut microbiota because there's an emerging link between the gut and the kidney. And we try to give our patient a lot of fiber, a lot of prebiotics, So the keto diet, if it's not supplemented, is very low in fiber. And most important, the PKD disease is a lifelong illness. So restricting diet are very difficult to follow in the long term. We have to consider the feasibility in the long life of patients. The long-term effects of keto diet are not known in the general population. So we don't know the effect in the kidney population. So in my opinion, it's too soon to recommend this kind of diet for PKD patients. So what is the best diet for PKD patients? Low glycemic index, so low sugar, yes, of course, high fiber, moderate calorie. It's important to keep body weight control, low osmolar diet with low sodium, low protein, but high water intake, but also low phosphate, low processed food, maybe low oxalate or low purine intake for patients who have specific kidney stone, but also high citrate intake with fruit and vegetable and lemon juice. So the best diet for PKD patients for me is more like the Mediterranean diet. A diet that is very, very high in whole food, all-free, fruit, vegetable, plant-based, protein, grain, and very low processed food to limit the intake of additives. And when you look at this, you realize that the PKD kidney-friendly diet in the real world is the same that the healthy plate recommended for the Canadian. A lot of fiber, a lot of fruit and vegetables, normal intake of protein, more plant-based protein, and high intake of water. So why should it be so complicated for a PKD patient to eat? Just use the common sense, eat a lot of fruit, vegetable, all food, and drink a lot of water. Thank you so much to have listened to me, and it will be a pleasure to answer your question for the few minutes, ongoing minutes.
Well, Roxanne, thank you so much for a very informative and engaging presentation. A lot of takeaways there. You ended it on, again, the importance of water, which even for me as a non-PKD patient, I don't drink enough water. And I have bottles in every room. I have glasses half full in every corner of the house. But when life gets busy and you get ahead of yourself, we all tend to slip on that. Knowing how important water is to PKD patients and chronic kidney disease patients, can you offer or revisit any tips or tricks to make it as easy as possible? I mean, is setting a reminder in your phone to drink a glass of water something that you would recommend? I know you've touched on flavoring it in healthy ways to kind of change it up, but revisit the water knowing the importance of it.
I think the best way is to have an application that can set reminder because if you have a glass of water in each piece and you don't have the you don't drink, you have maybe needs an application. It's important to have a gold. As I said, a graduated bottle is interesting because you know how many water you have drunk in the day. So it's a good way to keep track of your water intake, and choose a bottle that you will like, that a bottle that you can bring everywhere. It's always the yeah.
I knew I needed it for your presentation, beside.
And you have to have a routine, like another glass of water with each meal, with each snack, which each time you go to the bathroom. So with a routine, it's easier to drink a lot of water.
Tell me a bit about, or your opinion. You spoke about apps to track your water. What is your opinion on calorie intake apps and health trackers of that sort that seem to be trending as well these days?
The calorie tracker?
Yeah, things where you put in your meal and it breaks it down. I mean, they're as reliable as you can make it.
Yeah,
you know, there's obviously a lot of guessing.
I don't use this kind of tracker. The eating have to be a pleasure, eating have to be easy, and I don't think that we have to focus on calorie. We have to focus on high quality food. When people eat a lot of fiber, a lot of fruit and vegetable, not too much protein, the calorie intake is not not high. So I think we should more focus on the quality of the food we choose than the calorie content. So this kind of a tracker causes anxiety. With food. So last speaker talked about the effect on the stress and depression and
mental health. Yeah,
mental health. So I think for me, eating it's a pleasure, it's a passion. So it's important to choose with the eyes and not with the calorie content.
Understood. Thank you. Next question. Is there a recommended blog for recipes that meet the best PKD diet? So you spoke about the Mediterranean diet. I know you, of course, have authored a book as well, which by all means I encourage you to plug. The PKD Foundation US has PKD health notes that we share as well, that sometimes are recipes or diets or tips and tricks depending on the season. What is your go-to? Cooking can be exhausting, and if you're not creative, cooking can seem like the worst chore in the world. How do you gain ideas and creative ways to keep it healthy?
Yeah, there's many kidney-friendly website with a section on nutrition. You have also the Canada's Kidney Foundation, also Oser les Saveurs, Spice It Up, that offer recipes. And every Mediterranean book of recipes can be used. You just have to pay attention of the protein content, because sometimes recipes have a large protein size so it's important to adapt the recipes, but when you know how to use salt-free, low salt ingredient, when you know what is a normal size of meat or fish, I think you can use many normal recipes and just adapt for kidney.
Portion control is something that obviously the PKD community, but the everyday community needs to better manage as well. So I think when you talk about the similarities between,
it's the same
food guide, yeah, it is. It's exactly the same, but we all need those reminders to scale back. Can you touch on coffee again and speak to, back in the day, there were studies that said caffeine was bad and could actually increase the growth of cysts. And that was retracted about 5 or so years ago. We hear that, within reason, I certainly wouldn't divulge the number of cups of coffee I have on the average day, but what would you speak to from a CKD, PKD patient?
I think it's difficult for each nutrient to have the answer in studies, because all study that concern food is difficult to do in the long term. So there are many confounding in all study about nutrition. So it's the reason why the recommendation to limit to 2 cups of coffee, that is normal consumption, seems good. Coffee is interesting for some patients because it's a source of magnesium that's important for acid-base status. It can also help energy, and so I think some patients have an increase of their hypertension with coffee, and some not. So it's very independent of the person. So of course, if there are an impact on the hypertension, I can suggest to reduce more, but it really depends on the patient of the rest of the hydration. So a patient that have difficulty to drink, maybe these 2 coffee help to have a higher intake of liquid.
Understood. Thank you. Would the dietary recommendations that you've spoke on today apply to both autosomal dominant PKD as well as autosomal recessive PKD?
Yes. Yes.
Short and sweet answer. The next question, how will calories be gained with restrictions of protein? And then their follow-up question is what you've already spoken to. What have you found about the keto diets with PKD? So you've touched on that. Speak specifically to how calories will be gained when you're restricting the protein.
It is the same concern for CKD patient. When we talk about protein restriction, it is not a real restriction because it is the normal recommended intake for the population. When we try to limit protein, we have to keep in mind that the calorie have to come from other source. So I recommend for my patient to do not restrict fat, good fat. So the use of olive oil or other good fat is encouraged, and also we have to eat more whole grain. People think that grain are bad, but all grain and refined grain are not the same. Fiber are really, really important for the kidney. So when we add whole grain, we add calorie, and with a small size of protein, whole grain, a lot of vegetable with good fat, it's easy to have a normal intake of calorie. What you should not do is to eat just protein and vegetable. The whole grain are really, really important. And whole grain help to maintain the blood glucose low. So it's another interesting fact. So we want to keep the blood glucose very low.
Understood. Thank you. Next question. I have Crohn's disease with an ileostomy and PKD with a GFR of less than 20. Do you have any specific diet tips for my situation?
Because of low glomerular function, we tend to reduce a little bit more protein, but with ileostomy, you are prone to have more kidney stones. So it's really, really important to drink the most you can, because maybe at this glomerular function, you can have a little liquid restriction. It depends on the patient. So it's very, very important to have citrate and maybe citrate supplementation, because the malabsorption tend to decrease a lot of citrate in the urine. So we give sometimes citrate, potassium citrate or calcium citrate supplementation to help reduce crystallization in the kidney.
Got it. Okay. Recommending high intake of fruit means high intake of sugar, especially fructose. There's no evidence that high sugar intake is beneficial in PKD, is there?
I always recommend to eat fruit with meal, because every time we have a meal, we have an increase in the blood glucose and insulin release, and then the glucose is going low. So if you eat a lot of fruit in the meals, we will have always a high blood glucose. But if you put with the meals, you can have the insulin release will help to reduce the blood glucose. So the timing of the fruit ingestion is important, and also you have to evit juice fruit. When I recommend lemon or lime juice in water, it's low sugar juice and it's very dilute.
Okay, thank you. We have a number of questions on vegetarian and veganism, so we'll go down that road for a little bit and see where it gets us. When choosing plant-based proteins, it seems that many of the prepared meat substitutes are high in salt. We have also heard that soy-based products can contribute to cyst growth. Can you please speak to both of these concerns that we encounter when trying to reduce proteins from meat sources? Thank you.
I don't recommend protein-based supplement that are processed, because yes, it's high in sodium and often high in phosphate additive. So I try to use all food protein-based, like legumes that can be used crushed to do a burger, or I don't think that soy in small amount is bad for the kidney. Some animal studies show that soy protein was beneficial, so I think tofu is a good choice. If maybe the use of high intake of soy can be a source of oxalate, so for some patients it can be a concern, but it's not all the patients that have to look at this. So for the majority of patients, legumes, tofu, peanut butter can be used as a plant-based protein.
And more specifically then about a vegan diet, so you would just go more strongly on staying on the legumes, the bean front, the vegetables, the fruit.
The vegan and vegetarian diet are interesting. I see the better result on urinary and blood tests for my patient on this diet. I know it's not the diet for everyone, but we saw patients that remain years without dialysis because of vegan or vegetarian diet. The phosphate is very low. They don't have acidosis. They don't have high potassium level. So it's interesting when patients are motivated to use this kind of diet with the supervision of the dietitian, of course.
Understood. Okay. Is there a general recommendation for daily water intake? Is it 3 liters?
Yeah, 3 liters is the amount in average okay to reduce person, but it depends if a person have a stomy, have diarrhea, have sweat.
Yep.
Maybe he can have to drink more. So it's the reason why we look in clinic at the osmolarity in the urine to see if it's enough. But if the patient eats low sodium and low protein, you don't have to drink many water in comparison of patients with high protein and high sodium intake. We have this observation in patients that are on tolvaptan. Those who eat a lot of protein and a lot of sodium have a urine output of about 10 liters per day, and those with low protein, low sodium intake have only 3 to 4 liters of urine output. So it has a big impact. So if you take if you eat a kidney-friendly diet, you have to drink about 3 to 4 liters per day.
Okay, what is your opinion on intermittent fasting or time-restricted eating versus eating 6 meals a day?
I think it can be possible because it helps reduce blood glucose, it helps reduce vasopressin if the patient drink during this time. But what is important is to reach the target of fruit and vegetable and fiber intake during the hour that the patient eat. So it's always the concern, because sometimes with the short duration of the eating time, the intake of fruit and vegetable is not enough. So if it's well done, I think it can be used with PKD patients.
Okay, do you recommend to avoid oxalate containing foods?
Not if there's not a problem in the urine. And what we know now is that oxalate in the urine not come from only from the diet. There's 50% of oxalate in the urine that come from the body. When we eat protein, we produce oxalate. So if a person restrict too much the oxalate, the microbiota reduce the capacity of metabolize oxalate. So if the patient don't have a problem with oxalate, we can measure in the urine collection. It's not necessary to restrict this.
Okay, thank you for that. Next question, why do some foods cause distension in PKD patients?
What?
Why do some foods cause distension in PKD patients?
Distension?
Swelling out, filling of the stomach, just like extension, the swelling of, I guess, of the abdomen.
Okay. Maybe it's gut intolerance. I don't think it's generalized. PKD patient can have irritable bowel syndrome like other patients. So we have to try to find what is the intolerance. Some people have lactose intolerance, some of them have gluten intolerance. So we have to make some tests to find what is the problem. And in some case, probiotic can be used or prebiotic. So it's really a case individual,
unique case.
It's not for all patients.
Okay, thank you. We have time for a few more questions. The next one, what about omega-3 to 6 ratio? Does this impact the kidneys?
I think yes. I think this ratio is important for the general health. I've not heard about specific study for PKD patient, but this ratio omega-3 to omega-6 is a ratio that indicate the inflammatory. It's a low inflammatory diet with high omega-3 and low omega-6, and what we have to know is omega-6 is very common in processed food because the oil used in processed foods are very high in omega-6, and protein animal have omega-6 too, and we try to eat less fish than in the past times. So sometimes people have a low ratio of omega-3 to omega-6. It can cause high inflammatory rate. I generally not recommend supplementation, but if there are blood abnormality or if the patient also have an inflammatory disease, we can suggest an omega-3 supplementation, or for omega-3 supplementation, or for patients that don't eat fish, no source of omega-3, so we can recommend this supplement.
Okay, thank you for that. Tips or recommendations for picky eating children? And believe it or not, I'm not asking this question for myself. How do you encourage children with PKD that obviously, you know, have different preferences in what they eat? They may be, you know, the child that wants chicken fingers or nuggets 6 nights a week, refuse to eat things that are green, and so on and so forth. You know how they can go. What would you recommend to parents to try and spice things up, no pun intended, to make it more interesting and creative for the children?
I don't work with pediatric patients, but some adults are.
Sure.
I think we have to focus on what we can do. For some patients and adults, it's difficult to reduce protein, or but it's easier to choose low salt option. Or other patients, it's difficult to work with a change in the diet, but we can work more with hydration. I think it's not urgent for the PKD child to be perfect in his diet, but maybe there's many fun thing we can do with fruit and vegetable. Sometimes the child don't like to eat all, but in fruit salad, or incorporate veggies in muffin, or this kind of or within soup. Or it's important to try to find a way to introduce, but we don't want to create a bad relation with food in children. So
absolutely.
Yeah.
Okay, thank you for that. We have time for 2 more questions. You emphasized a number of times in your presentation about kind of restricting the amount of times you go out to a restaurant, and how that's the biggest place where hidden salt can be found. That's easier said than done, especially in this day and age, you know, when things are kind of at a standstill in society. People are ordering in more, they're going out more when they're allowed to. For those that do tend to go out to the restaurant, other than hiding the salt on the table and going after the obvious marked health check foods on the menu, are there any kind of idiot's guides to making good decisions while at a restaurant?
In the restaurant, first try to avoid the table d'hôte, the how do you say, the entry meal,
appetizers.
Yeah, try to avoid the appetizer because it adds a lot of sodium. The soup, a soup in a restaurant is about 1,000 milligrams of sodium. So it's very, very high. So I recommend to my patient to choose just the general plate. And there are many interesting options. So for the side, just ask for baked potato, because we know that in the baked potato, there are not salt add with we can also choose for a steamed veggie. It's available in many restaurants. So all potatoes, steamed veggies, and try to choose not a meal in sauce. When you choose fish or small steak or small grill or chicken, it's easier to see the size of the protein.
Sure.
So when you choose this kind of meal, it's really it's more easy to control the sodium. So avoid dairy meat like pizza or this submarine, or avoid pasta with very salty salt, yes, or Chinese meal with soy sauce. So you can make good choice when you go in restaurant. So
okay, great, thank you. Last question. Ketogenic diets have been shown to reduce CVD risk and hypertension. You said that that's the opposite. Now, this individual is hoping for some clarification. So can you speak again to your concerns or your opinion on the ketogenic diet that has been shown to reduce CVD risk and hypertension?
There's no a study that shown the effect on the long term. Term. So what we saw, because we have some patients that try this diet, is that a worsened lipid blood result. We saw more proteinuria. We always saw an increase in metabolic acidosis and kidney stone. So the keto diet can be earth friendly if there are no animal fat, if there is just vegan keto diet, but it's not the diet that is more common for patients on keto diet. So very, very earth friendly keto diet with enough vegetable, with supplementation of citrate, supplementation of vitamins, it's not a normal diet, but it can be healthy for the earth. But it's not what we saw with a patient that just decide to go on keto diet. So it needs to be well done, and with a strict monitoring of the urine, of the blood lipids, and acidosis. But in many cases, we saw a deterioration in the short time. Patients have worsened their lipid result in 6 months. So it's very, very it's in short direction. So the effect on long term, I'll talk about 5 to 10 years. We don't know.
Okay, thank you for clarifying that. There's one last comment here that just says, this has been an absolutely fantastic presentation. Will it be posted on YouTube at a later date? So I get to answer this one. These presentations are being recorded. We will host them on npkd.ca, and they will be on our YouTube channel as well, so we can absorb all of the information that was shared today. Roxanne, I can't thank you enough for your time and dedication to the CKD-PKD community. Thank you so much for joining us today.
Thank you.
I wish you all the best. Please take a moment. I told you to plug it.
Yeah, I have a new book. Unfortunately, it's only in French at this time, but I tried to get it translated. For those who are French patient, there's a book with a 3-week all menu for CKD and PKD patients. So it's available in Canada
Wonderful.
and Europe.
Wonderful, fantastic. Thank you very much for adding that in, and we wish you all the best. We'll talk soon. Bye, Roxanne.
Bye.
Well, everyone, that concludes another one of our virtual PKD summits. I can't thank you enough for joining us today. There is a survey link in the chat box now. I do encourage you to submit your survey. It's how we learn how to improve our events, how to make the best presentations possible for you in the PKD community. We do have one more remaining virtual summit, which is taking place next Friday. Registration is available online, so I do encourage you to check it out. If the topics are of interest to you, please join us again. Don't hesitate to reach out to us at any time. npkd.ca is our website. We have all our contact information there. Again, a huge thank you for everyone involved in today's summit. Thank you to Live Agency, of course, for all their behind the scenes work in making this possible. And we at the foundation look forward to hosting you next Friday. All the best. Bye-bye.